So we have, as usual, quite a few questions here. Dr. Neville, we'll start with you. There are actually several questions about the anatomic difference where some people have an L6.
Oh.
And wondering about the implications for that, for sacroiliac dysfunction and either one of you, whoever can answer.
Well, I would say that's a really good question, and I just have some experience about it. I can't really respond from any knowledge in the literature, and I'm not a spine doctor. I think that oftentimes we see people with an L6 and they have one facet that's sacralized, so the L6 vertebra is fixed to the sacrum, and it really causes a lot of imbalance through the pelvic girdle. So I think that they may likely have more sacroiliac joint dysfunction, and that's just my speculation.
Okay. So Dr. Spencer Gardner, we have a couple of questions about labral tears in EDS patients and whether they're more common and whether the approach to management should be different in people with EDS than in the general population.
Great question. I don't know if, I'm not aware if anyone's done a study looking at prevalence of labral tears in that specific population, but I think the take-home point from my research in this area and from the work that people have done is that I think as orthopedic surgeons, we can certainly help in instances, in certain situations and scenarios. I think most reliably when there's underlying structural problems that are contributing to pain and dysfunction. Unfortunately, there's only so much we can do in the setting of abnormal structure and tissues. We can repair structures, but we can't make the constitution of the tissue normal again, or normal, period. And so repairing isolated labral tears and fixing or plicating capsule, these procedures have been done, and we have shown improvement in patient symptoms. I don't think it's hard for us to be able to guarantee that we can fix those problems. I think we can make a positive change and a difference without fixing and completely addressing it. And I think, again, most reliably when we're treating underlying hip disorders in the setting of hypermobility, I think that's where we'll probably do our best work.
Thank you.
Thanks.
Dr. Brooke Spencer, there's a question here about the use of stents in patients with mast cell activation syndrome and whether you're able to test for sensitivity to the materials that the stents are composed of before they're placed, and whether this is an important consideration for those patients.
Yeah, can you hear me?
Yes.
Okay. Yeah, it's an excellent question and one that we're trying to answer right now. So I would say that probably 60 or 70% of the patients out of about 800 we've treated have mast cell activation or an underlying autoimmune disorder in addition. And about 17% of women have, and about 5% of men have a known nickel allergy or sensitivity. So most of our stents are made of nitinol, which is nickel and titanium. So we get this question a lot. So for the first few years that we started treating patients, we wouldn't even consider treating patients with a sensitivity or an allergy. And over the last several years, when we've gotten more confident that some people that are very disabled from this would benefit, we started working with an allergy group here in town, and we got samples of the stents from the companies, and we've been patch testing people to the stents themselves in addition to the traditional nickel testing. And about 50%, the vast majority of patients that think they're allergic or not, actually it's not the vast majority, it's about 50-50, that the nickel allergy and titanium allergy testing comes back negative. In the other 50% where it's positive, we started off with people that had a sensitivity reaction but did not react to either stent and started stenting them. They all did fine. Then we took the patients with a 1+ nickel allergy reaction after very careful discussion and stented them when they did not react to the stents themselves, and they did fine. And now we're up to having stented about 20 people with a 2+ nickel allergy reaction, and we haven't seen any problem. When we get to 30 patients in each group of the negative patients and the positive patients, we'll have enough to have a statistical analysis between them. And we're gonna look not only at pain and systemic reactions, but every one of our quality of life surveys, every data point that we collect, and see if we could tell any difference between the two. So far, the answer's been no. And if you look at the neurosurgical literature or neurologic literature that looks at coils and stents they place in the brain for aneurysm and emergent stroke data, the data would suggest that the amount of nickel that's detectable in the tissues adjacent to these structures is negligible at 60 days and it is invisible at 60 days and at 30 days negligible. And their recommendation is that we do not need to be testing people for metal and allergy sensitivities. So at this point, if you think of all the millions of people who come into the emergency room with heart attacks and go straight to the cath lab and get a stent, and all of the rest of the people in the world that get extensive DVTs or other things and get stents, patients who get surgeries and gallbladder removals and other things where they have metal put in them and we're not testing, the suggestion would be that the concern may not be warranted, but I don't think we clearly have that data yet, although I'm much less concerned than I used to be about that concept.
Thank you. That's a really comprehensive answer to that question.
I know, I don't mean to hog the time, but it's a question that's hard to answer, so.
Yeah, no, thanks so much. So the question also comes up with regard to mesh in the placement in surgery for pelvic floor dysfunction. What's your feeling about that?
Well, I'm not a surgeon, so it's not my area of expertise, but I know that because of the history of problems with mesh in the past, there's been a lot more research. And I think that overall it's considered to be much safer now because of the new information that we know.
Okay, great, thank you. All right. So, Dr. Spencer Gardner, so many questions here. There's several questions about hip subluxations. And the best strategy for thinking about that, if they're not frankly dislocating, what are your strategies? What would you recommend to people?
So I think the hip subluxation is a tricky one because it's very difficult for us to appropriately diagnose that. You can do dynamic ultrasounds, or you can do some more recently, the ability to do advanced imaging dynamically can give us some more clues or feedback as to whether that's truly the case. As I think I alluded to in my presentation, a lot of times there's abnormal motion of the soft tissues, fascia, tendons crossing over bony prominences around the hip, which can often feel they are mechanical in nature, and can give the impression that there's an instability or abnormal movement of the hip joint proper, but it may be tendon muscle moving around the hip joint. And so I think the first question is, are we actually dealing with a true subluxation event? Because the hip overall, even in the setting of abnormal lax tissues, the hip overall is a fairly stable joint as opposed to the shoulder, which is a much more shallow socket, so to speak, the glenoid being much flatter and more shallow. The hip is fairly well contained and constrained. And so the likelihood of there being true subluxations where the ball is almost coming out of the joint, I think is difficult to truly determine. For strategies on how to minimize or prevent those kinds of symptoms, I think bracing is probably the best one. Some biofeedback that comes from that for patients to kind of give them the sense of stability with the brace as well. I think that are probably the best strategy. Part of our job as surgeons, if we go to the operating room, is that we're going to tighten tissues and tighten ligaments around the hip with an arthroscopic procedure. So that's something that's top of mind. We don't want to create problems, as we mentioned, by attenuating those capsular tissues. We want to strengthen them, if anything.
Kind of related question, someone asked whether the use of compression garments at night might help with somebody with unstable hips. Do you recommend that?
Yeah, look, I think I don't have good science to back it up, but I think in those kinds of situations, that biofeedback piece is important. And then in general, I encourage patients, if something is helpful and is working, continue doing it. If I don't have good evidence for or against, that's ultimately the final recommendation, is to try, and if it's helpful, then please continue.
Can I add a little thought to that?
Sure.
So I discussed the concept of ligamentous creep with the sacroiliac joint, and this probably happens at other joints as well. And so patients that I've worked with have talked about their hips subluxing after they've been sitting for a while. One of the most common sitting positions of hypermobile people is cross-legged. You're trying to wind up everything and stabilize everything. Now you're sitting like this for 2 hours watching a movie. Now your ligaments have stretched, there's some creep, you stand up and the ligament pops over the bone and it feels like it's subluxing. So it's really, you have to be Sherlock Holmes and figure out when is it happening, what were you doing before it happened, and then can you change that situation and see if it stops happening. Easier said than done.
Right. Okay. Dr. Brooke Spencer, several people asked about there are many people who have multiple compression syndromes. They may have May-Thurner and Nutcracker and Mal's. And do you have a strategy for deciding, like, how do you prioritize the interventions for those compressions, and what are the risks to the other ones while you're waiting for the first ones to be taken care of?
Yeah, I'm really glad actually that someone asked that question, because there's a lot of misinformation floating around out there on the websites and the Facebook groups about this. So I guess what I would say is that we need to remember that every patient's an individual and each person has different symptoms, and each one of those applies differently to their own individual anatomy. So recently I've heard a lot of people talking about a top-down approach, and there is no medical or science behind that, so that term should be thrown out. I've heard a lot of people say that if you fix the iliac vein, you make the nutcracker worse. There's no possibility of that whatsoever. So that needs to be thrown out as well. So what I would say is that different conditions cause, or are more likely to cause, different pieces of this puzzle of. So Mal's causes upper abdominal pain, nausea, vomiting, mid-chest pain, mid-epigastric pain, right? And Nutcracker causes left flank pain and hematuria, but with collateralization in and around the spinal cord and the mid-spine, it can also cause upper abdominal pain, food fear, nausea, and be very confusing or confounded with Mal's, even though the classic Nutcracker is left flank pain and hematuria. The iliac vein contributes to those symptoms in the sense that nausea is very common in patients with hypoperfusion, which may be coming from iliac vein compression, but the pelvic and lower extremity and back symptoms are more common with that disease. The only way that you get worse pelvic pain with stenting the iliac vein is that if there's also a nutcracker with reversed flow in the ovary vein, it gets worse after you drop the pressures in the pelvis. So in that sense, it is possible for treating one to result in a shift in symptoms in another area, but in most of those patients, they would have required treatment of everything to become asymptomatic. So I think the good news is if you go to a specialist well-versed in all of these, they can help you decide based on your own symptoms and your own anatomy, which things should be addressed first.
Great. Thank you so much. Dr. Neville, there's a question about, this is from a medical professional who sees many patients with low back pain, and they're commenting that it can be challenging to differentiate between low back, SI, and hip issues, and wondering whether there's specific indicators that can help distinguish the pelvic issues from the others.
Well, I think that what we have as therapists is our physical examination. So that's what I can speak to. And if there is full, active, pain-free range of motion in the lumbar spine, then it's very unlikely that that is driving the pain situation. Learning how to perform provocation tests of the sacroiliac joints would be important. Things like the thigh thrust test, forced Faber test, the Fadir test to rule in and rule out any provocation of the hip. And then the other thing that we do clinically is maneuvers to relieve symptoms. So, for example, a classic one of the hip, if a person has an arthritic hip and we do a gentle distraction and it relieves their hip pain, then that gives an indication that it's more hip. So really, it's working on learning your physical examination skills and trying to rule in and rule out the different aspects. So I hope that's a helpful answer.
Right. So you need a generalist looking at this person, right?
Yes, well, as a pelvic therapist, oftentimes people don't understand that I'm also an orthopedic manual therapist. And so it does take a combination of knowing and learning how to evaluate and treat the lumbopelvic hip area in order to be able to do that. So if you don't have training and education and you only have training as a pelvic therapist, then you can't do that. And what we recommend for patients who are seeing pelvic therapists who don't have the orthopedic skills is to see if they can work together as a team with an orthopedic physical therapist, so that between them, they can kind of rule in and rule out, is the pelvic girdle contributing to the pelvic floor dysfunction or not?
Great. Thank you so much.
If I can make one comment on that as well, is
Yes.
that we have a very large number of patients with significant low back pain as a part of their iliac vein compression syndrome. And we work really closely with our pelvic floor physical therapists. And when they can't explain it and don't think it's related, then we've worked with them as well. And I've seen several young patients have orthopedic surgeries on their spine. That don't improve their symptoms. But we've also seen a lot of patients that have had their back pain resolved after stenting, because if they are collateralizing in and around the epidural venous plexus and sacrum, it can also contribute. So hopefully we'll gain more information as we study this more from that standpoint as well.
Yeah. It really speaks to the importance of having a full differential diagnosis and then systematically working your way through it, right?
Mm-hmm. And having access to a good interventional radiologist, which not everybody does.
Yeah. Dr. Spencer-Gardner, there are a couple of questions about PAO surgery to correct hip dysplasia and whether there are additional risks for people with EDS for that surgery. First, could you define it for us, please?
Sure. The PAO, we touched on that procedure a little bit. It's where you're making the cuts in the bony pelvis around the hip socket to enable you to take it from a shallow position and then reposition the hip socket and then fix it in place as though it were a pelvis fracture. So it allows you to reorient the hip socket and put it into a new position. The only study that I'm aware of that looks specifically at this population was the one that we talked about in the presentation, was Johan Witt's series in London, and he looked at he had 220 hips, 200 odd patients in that series, and I think close to 20 of them were on the hypermobility spectrum with either EDS or HSD, and so in that group they were 2.5 times. They had a 2.5 times higher risk of complications around surgery. Most of those complications were lower grade complications, so they may have changed their therapy protocol. For instance, there might have been a fracture beyond one of the ones that they created that may have changed their weight-bearing protocol during physical therapy, for instance. I believe there was only one reoperation in that group that had 2.5 times increased risk of complications. And I believe that reoperation was either for an infection or a tendon release. I can't recall exactly which one, but it was a relatively any trip to the OR is a big deal, but it was a relatively minor procedure. There can be some serious complications after that surgery. You're making cuts in the pelvic bone adjacent to vital blood vessels and nerves, and those complications are reported in the literature. So it's not a surgery that you take lightly. The indications to go to the operating room obviously must be there, but I think if there's any underlying dysplasia in a hypermobility in a patient with hypermobility disorder, I think it's imperative that you're able to optimize the bony structure. Mm-hmm. and the hip socket. The acetabulum is a big part of that, and so that's a powerful surgery to enable normalization.
Yeah, thank you.
Thanks.
Okay, I think we have time for one last question. Dr. Brooke Spencer, there are several people asking about where should they go for the initial evaluation for suspected compression syndromes? What type of doctor would be the person to evaluate this?
Yeah, so I mean, it's a loaded question, right? Because there's not enough data, and there is really sadly a lot of shaming of patients and their symptoms going on in this space. And I think it's because when people have symptoms in every organ system, right, and nobody knows how to tie it together, then we start to question whether it's really real or not, right? And we need to stop that behavior as medical practitioners, which most don't, but many do. And start listening to our patients and put it together. So, I mean, I have a license in 50 states because over time people have been referred to me because this is all we specialize in now. And we've been able to kind of differentiate, order MR venograms we've created a special protocol to be able to help and diagnose this. I have some colleagues across the country who really believe in this in different spaces and spots around, and who are studying this and looking at it as well. I have other colleagues who've told me they think it's a nice idea, but they'll consider treating people once I show them the data. So we have hired a full research team. We have multiple grants. I've started a nonprofit organization to try to raise money for this and try to put our money where our mouth is, right? And really get the data, because quite frankly, stenting young patients is very controversial. And I think that we should get to the data, and we have to start somewhere. So we've concentrated the experience with ourselves, and I apologize to the patients that I don't know. I mean, there are several other practices, and you could maybe find them online that are considering this and doing this, but not a lot.
Wonderful. Thank you.
I'm sure they go to Mayo.
Okay.
Did she say Mayo?
Yep. Dr. Devchich.
So please give a big round of applause to our speakers. Thank you so much for a very informative session.